right. It's coming up to 12. We will start in about a minute's time. There are a few people still joining. Right, I think I'm going to make a start, Doctor. So,
yeah, that's fine.
Okay, good afternoon, everyone. Welcome to Umesh Shah Presents Sunday Life and Learn Talks. Today's speaker is Dr. Debasish Das, who will be talking to us about liver disease. In a presentation titled, There is More to Liver Disease Than Alcohol. Dr. Das trained in liver diseases at Leicester and Newcastle and has been a NHS consultant since 2010. He has been involved with clinical care of patients and also as a principal investigator for several research projects. He is also an educator for undergraduate and postgraduate training and training program director in gastroenterology for Southeast Midlands. He is also a member of the examination board of the European Specialty Examination in Gastroenterology and Hepatology and represents the Royal College of Physicians of London on the Joint Specialty Committee for Gastroenterology and Hepatology. Dr. Das is currently a consultant hepatologist at Kettering General Hospital and an honorary senior lecturer at University of Leicester. Dr. Das, I'll hand it over to you to start the presentation.
Thank you, Ms. G. And welcome, everybody. Hopefully, we'll have a session of discussion at the end. So, I'll start off. Okay. So why I chose this topic is that quite often when I get patients in my clinic and the GP has referred with, we've got liver problems, the first thing I hear is, oh, doctor, I don't drink alcohol, so how can I get liver disease? And this is where I want to emphasize that there is more to liver disease than just alcohol. So I'll cover a bit more of the liver, like this topic, in the following ways. I'll first talk about the liver as an organ and its main functions, talk about a bit of functional and structural changes in the liver, phases of liver disease, manifestations of liver disease, and causes of liver disease. We'll talk a bit on progression and prognostication. So the liver as an organ, it's the second biggest organ in the body and is the biggest solid organ. It is situated at the top right-hand part of the abdomen. A lot of people do not have that idea where the liver is, so I just wanted to make sure that that's well understood. The liver is like a doorway-shaped organ. It has got two blood vessels that feed into the liver. This red one is the artery, and the blue one is the portal vein. It also produces bile, which is drained by a tube called the bile duct. It gets stored in the gallbladder and then released into the intestine, helping in digestion. The blood from the liver leaves the liver through three blood vessels and go into the big blood vessel that feeds into the heart. So that's basically the circulation in the liver. In terms of the functional components of the liver, it's made up of tiny cells called hepatocytes or liver cells. If you imagine this as tiny machines arranged in layers. The blood vessel called the portal vein brings in all the digested food material from the intestine and feeds it into the liver. The hepatic artery brings in oxygenated blood and that percolates to the liver, giving its oxygen. It produces several materials that goes into the bile, this green layer going through into the bile duct and drains into the intestine, helping in digestion and elimination of certain chemicals. The blood then leaves through the central vein here, and that's the main circulation inside the liver and how the liver is structured. The liver has got over 500 functions, of which it can be classified mainly as transportation function. So it produces bile, cholesterol, and other products that transport certain other chemicals attached to them or dissolved in them and goes to supply the waste materials along with the kidneys. It also produces several chemicals which are important in blood clotting, maintaining the nutrition of the body, and also certain other chemicals that help in various chemical processes that maintain health. It detoxifies a lot of products, and a lot of the symptoms that a patient with liver disease gets is due to the failure of detoxification of materials that should have been removed from the body by the liver. It's one of the major handlers of the energy source. So when we eat and digest our food, the food is then broken down into simple molecules that goes to the liver for storage as sugar. The sugar is then released into the blood when we are not feeding, and that allows our bodily functions to carry on. The liver is also associated with waste management. So it detoxifies several chemicals, as I said before, and it then dumps it either into the blood to be circulated through the kidney to remove it, or through the bile to be removed by the stool. In terms of what it does, as I said, it also helps in immunity by various destruction of various pathogens. It produces certain immunoglobulins which help in immunity too. It creates blood clotting factors, and therefore when the liver is not working well, a lot of people tend to bruise and bleed. It stores fat, protein, glycogen, vitamins, copper, and iron. Now coming to the functional and structural changes of the liver, even in the days of the Greek mythology, it was known that the liver can grow in size. But actually, whether it was the principle that was known or just that in people who had liver problems, they tended to have regeneration is not well known. It can not only regenerate in size, but it can significantly regenerate in its functional capacity. But what is important to take on board is that while this capacity to repair and work again is there, it is actually not immortal. There does come a time when it has had enough and it starts failing. It's also important to differentiate the chronic changes of fibrosis or scarring from the functional capacity changes. So if you compare a liver to a car, you can have a car which has got a brand new engine, a brand new body. That's the normal liver. But sometimes you get cars that have lots of dents in the body, but takes you from A to B very well. And that is part of a chronic liver disease where there is scarring in the liver, but it's still functioning well. But at a time comes when the engine does still to cause problem, and that's when the chronic liver failure starts. So it's important not only to assess the functional aspects of the liver, but also to look at the liver stiffness or scarring when we are assessing the liver. The traditional term liver function test, which includes several blood components, are only telling the half the truths because it does not assess the liver function as such. And it can be normal even in patients with cirrhosis. The other thing that one needs to keep in mind is that the liver has a limited portfolio of structural changes to a variety of insults. So it can have acute inflammation, fatty changes, immune-mediated damage, granulomas from certain infections or inflammation, enhanced cell death, and congestion from mainly heart failure. It will generally present with ongoing scarring, and that ongoing scarring can then lead to cancer formation or liver failure. So coming to the phases of liver disease. So it can have acute liver insult or chronic liver irritation. And in a patient who have got chronic liver irritation, there can be an acute insult which can destabilize a stable disease. But also without acute insult, as I said, there is a limitation to how much regeneration can happen in a chronic liver disease. And that then leads to progression of the chronic liver disease. So keeping that in mind, if we look at acute liver failure, the commonest cause of acute liver failure, as you can see here, varies between the children and in adults. And as you can see, alcohol does not come into the first 6 on either of them. The acute liver failure is classified into 3 types: hyperacute, acute, or subacute, depending on how quickly the patient changes from just having a bit of jaundice to becoming seriously ill or having what is called encephalopathy. In most of these cases, there is the hyperacute one, or where the change happened very quickly, is generally the commonest one and mainly seen with paracetamol poisoning as the commonest cause in the UK and the US. Overall, if you can manage the acute phase quite well, the prognosis can be quite moderately good and they recover quite well. However, in other cases where there is drug-induced liver injury or autoimmune diseases, the prognosis can be rather poor. Well, in the chronic liver disease, as I said, there can be general progression of the chronic liver disease over many, many years, and that can lead to dysfunction of the liver and its effect on other organs of the body, leading to a multi-system failure. However, there can be interruptions or aggravations of the prognosis by acute insults. Like if somebody with chronic liver disease gets a second infection with the hepatitis virus, or gets liver surgery, or has excess alcohol intake suddenly, that can aggravate the process and make it faster. So coming to some of the manifestations of the liver disease, it's also important to understand that the manifestations of damage and scarring are essentially the same, irrespective of the cause of liver damage. So just looking at a patient with features of liver damage, it's often very difficult to say what the cause of the liver disease is. There can be certain specific cause changes that give clues to the etiology, but these are quite often subtle and may not be outwardly discernible. Often there is also more than one reason why somebody gets liver disease. And while somebody who drinks alcohol can get liver disease, it's worth looking into other risk factors. So in terms of the acute liver disease manifestation, as you would see from this, that they are very non-specific, generally feeling a bit unwell, tired, loss of appetite, generalized aches and pains, nausea or vomiting, and then developing jaundice or yellow discoloration. They may have low gate temperature. They may get an aching sensation in the right upper part of the abdomen. The urine can become quite deep colored, and later they can have changes in behavior, sleep pattern, shakiness of the hands, and disorientation. As you see, these are non-specific changes and can mimic other causes of problem, especially neurological causes or infections. Acute liver failure is a multi-organ failure. It's not just the liver that fails. The liver fails, and that leads to failure of function of other organs because they're all interconnected and dependent on the liver doing a lot of the jobs that are shared by other organs. The manifestation of chronic liver disease are, however, much more easily understood. You get fluid retention leading to distension of the abdomen or swelling of the legs. On ultrasound or other scans, you get a knobbly looking liver. Dilatations of veins on the abdominal wall is quite common. Changes in the hormone balance can lead to gynecomastia or enlargement of the breasts. There's also increased risk of bruising and bleeding. The red spots called liver spots or spider nevi more technically are quite common. You get this blotchy redness of the palms, quite often visible. The yellowish discoloration of the eyes. The nails become more brittle and there is white changes at the base of the nail. Sometimes the nail becomes swollen or is called clubbing. As the liver disease progresses and toxins starting building up, the brain starts becoming a bit obtunded and you see neurological changes, including an inability to lift the hand like this and keep it there. They tend to shake, called asterexis. Also, there is something called fetor hepaticus, which is a faintly sweet smell in their breath because of certain toxins that they expire. One of the things that was previously not sort of appreciated well and is coming into focus is something called sarcopenia, which is loss of muscle mass. And this is contributed to by various things, but is increasingly being recognized as one of the most important factor in survival of these patients. Complications in the late stages of liver disease will increase easy bruising, muscle cramps, anemia and shortness of breath, and increasing difficulty with walking, maintaining balance. Sometimes internal bleeding happens, leading to vomiting of blood or passing very black, dark stools. Subtle changes in personality, memory loss, and mental confusions are not uncommon. They're also more prone to infections, including infection in the abdominal fluid and deterioration in kidney function. So why is liver disease important? As you can see from this graph over the years, the only major cause of mortality that has been increasing year on year is this red or pinkish red line of liver disease. And this has gone exorbitantly high over the last few years. Also, interestingly, and as expected, probably from medical perspective, the death from liver disease tend to happen in much more younger age group, mainly in the 50s to 60s and 60s to 70s, rather than with cancers or stroke or heart disease, which tend to happen in much older age group. So there's a lot of, loss of working lives that are lost to liver disease. Now coming to the causes of liver disease apart from alcohol. So if you go to the British Liver Trust website, and if you're interested in liver disease, I will encourage you to do that. Have a look at the information there. It's got lots of information. In the liver conditions section, you will see a whole long list of liver conditions, including alcohol-related liver disease, non-alcoholic fatty liver disease, and infection-related liver disease. In the UK, alcohol, non-alcohol, and infections with hepatitis B and hepatitis C makes the majority of causes of liver disease. But apart from this, there are various other infections, several viruses like Epstein-Barr virus, cytomegalovirus, certain other organisms like cystosoma, hydatid cyst, amoebic abscess, and bacterial diseases, including tuberculosis, can affect the liver. Medications and toxins are also significant causes of liver damage. And as you can see, the commonest cause is antimicrobials or antibiotics, causing up to about 50% of damage to the liver from drug-induced liver disease. Another cause that you need to be careful about is the contribution of herbal and dietary supplements, especially those that have got element of steroids in them. So why does not everybody who takes antimicrobials end up with liver disease? And that's because how a medication or toxin affects a person is dependent not only on the type of the medication or toxin, but it's also denoted by the genotype or what the genetic makeup of the patient is, what other medications they are having, whether they have got other lifestyle choices or diseases that already make them prone to getting liver disease. There are several genetic changes that causes liver disease. One of the commonest cause being Gilbert syndrome, which is generally a very benign condition with no real damage to the liver over time, but can present with mild jaundice from time to time. There are other conditions like benign recurrent intrahepatic cholestasis, deficiency of certain materials like alpha-1 antitrypsin. This can be affected also in cystic fibrosis, certain genetic conditions which accumulates iron, which is hemochromatosis, or copper in Wilson's disease in the liver. Porphyria, you might have heard about, that also can affect liver disease. Another big group that causes liver damage is immune-mediated damage. Conditions like autoimmune hepatitis, primary biliary cholangitis, primary sclerosing cholangitis, and immunoglobulin G4 induced cholangiopathy are quite well known. Also, certain conditions like systemic lupus erythematosus, which is a rheumatological condition, can also have damage in the liver. There are certain conditions like cholestasis of pregnancy, acute fatty liver or pregnancy, or HELP syndrome that are specific to pregnancy that can affect the liver. The blood vessels we talked about in the early part of the presentation, they can get damaged or blocked off, causing certain conditions like Budd-Chiari syndrome, portal vein thrombosis. And sometimes childhood surgeries like Fontan procedure or Kasai procedures can leave long-standing damage to the liver. So as you can see, there are lots and lots of causes of acute and chronic liver disease apart from alcohol. Coming on to some of the benign tumors and cysts, and this is again a very common thing. We do ultrasound of the liver or scans of the liver for certain other conditions, and then you pick up cysts or dilated blood vessels or benign tumors like focal nodular hyperplasia or adenoma. Certain cancers like hepatoma, cholangiocarcinoma, or metastasis from other conditions can also affect the liver. The causes of liver disease varies from country to country. So as you can see here, in most of the European countries, a significant portion does come from alcohol use, which is in the light blue area, but there is a distribution of other causes contributing to the proportion of liver disease. If you now go on to the worldwide prevalence, as you can see, the green portion here, which is alcohol-related damage, only contributes to a small proportion compared to hepatitis B or hepatitis C related damages, because a lot of the population are concentrated in Asia and sub-Saharan Africa, where hepatitis B and C are much more prevalent. In the UK, yes, alcohol still causes the most damage in terms of frequency that leads to need for transplantation. As you can see, non-alcoholic steatohepatitis, primary sclerosing cholangitis, hepatitis C, and primary biliary cirrhosis are catching up. During the COVID pandemic, we've seen a 21% increase in alcohol-related liver damage, but it is difficult to say how much of this is coincidental to direct damage by the COVID virus affecting the liver itself. It's probably multifactorial that there has been an increase in the liver-related deaths in the coronavirus pandemic time. Coming to alcohol, all alcohol are not the same. It does have different units in the same volume. Also, there are different calories to the drink that you have. So you need to be careful that while you're measuring units, quite often the calories that comes with it also needs to be taken into account. With normal liver, when there is significant alcohol use, there is steatosis of fatty changes that can also lead to acute inflammation, and that can slowly progress to liver fibrosis. Not everybody who drinks will get liver disease or get advanced liver disease, because there's a lot of other factors that modify the effect as to what damage happens with alcohol in the liver. With the increasing pandemic of, or epidemic of obesity, hypertension, and diabetes, non-alcohol related fatty liver disease is becoming a significant factor in generating liver disease in the community. And when it is associated with an alcohol use also, there is a significant increase in the risk of having liver damage from the fact that if you are just slightly overweight but did not drink alcohol, or drank alcohol to an extent but did not have obesity. When the two comes together, there is almost a 10-fold increase in risk of developing liver damage. In the UK, there is a significant increase year on year in the prevalence of non-alcoholic fatty liver disease. Also, it's not just the UK or developed countries like the United States that have got increased levels of prevalence in fatty liver disease. As you can see, in India, China, Japan, there is significant variation, but overall there is a prevalence of liver disease coming between 20 to 30% in modern studies. So it's not just a developed country's problem. There is a concept of insulin resistance. Insulin is important in metabolizing sugar in the body. When there is resistance to insulin, the sugar does not get into the right place. It is stored as fat, and that causes several consequences, including damage to the liver. And there are several factors like gender, age, ethnicity that plays a role in who develops progressive damage in liver disease with non-alcoholic fatty liver. There are certain conditions that have been well associated as drivers of progression of liver disease with fatty liver, like obesity, alcohol, type 2 diabetes mellitus, insulin resistance, and various other emerging factors that are associated with progressive damage. There is a slow but steady stage-wise progression from normal liver to fatty liver with inflammation or NASH, and then fibrosis and cirrhosis. The time taken can vary depending on various risk factors, as I mentioned above. The problem with non-alcohol related fatty liver disease is that quite often there is subtle blood test abnormality. There is slow progression with very little manifestation in the early stages of problem. And when they're present with decompensation or advanced liver disease. And it is currently the commonest cause of liver cancers in the UK in the last few years. And even with just a bit of fatty changes in the liver, there is an increase in the cardiovascular risk. It's not just liver disease related problems that these patients have. They quite often have progressive and quite significant cardiovascular disease. Coming to viral hepatitis, the two common ones that causes chronic damage are the hepatitis B and hepatitis C. And quite often they can coexist because they are transmitted by body fluid and blood, and they can quite commonly coexist with the HIV infection. There is a significant burden of hepatitis B in Southeast Asia, as you can see the deepest colors here. And also hepatitis C is also quite predominant in certain parts of the world, including Southeast Asia, Pakistan, Mongolia, and North Africa. Hepatitis B is transmitted through blood and body fluid-borne transmission. It can also cause vertical transmission from mother to child. And when it's acquired in the childhood, 85% of people will have a chronic disease. It'll increase the risk of liver cancer. They require regular checkups. And at the moment, the curative treatment options are still not very good. But it has got an effective vaccine, and the main focus is on transmission prevention and then controlling the virus once infected. With hepatitis C, the route of transmissions are essentially the same, but in the UK, the commonest transmission, up to about 90%, happens from intravenous drug use. And even a single episode of intravenous drug use has been shown to transmit infection. Again, chronicity rates are around 85%, but unlike hepatitis B, there is no licensed vaccine as yet. On the other hand, there has been a revolution in the curative treatment, and therefore it's important on finding people who have hepatitis C, diagnosing them, and getting them to treatment to prevent longer-term damage. As I said, there is a problem of mother-to-child transmission of hepatitis B and C and HIV, and we quite often have projects that tries and reduces the risk of transmission. There are several websites I would suggest if you're interested to look at. There's the British Liver Trust, there is Liver North, there is the UK PSC for primary sclerosing cholangitis, the PBC Foundation. These websites have got lots of validated, simple language information on liver conditions. There are lots of, in the Liver North website, there is a section called Publications. And if you go there, there's significant amount of very patient-friendly, easy to understand information leaflets that I would encourage you to get and have a look at. So coming to progression and prognostication. So whatever be the cause of liver irritation, especially in the chronic phase, it slowly but progressively causes inflammation, damage to the structure, and changes in the blood vessels in the liver. Over time, it leads to early fibrosis. As to how quickly somebody progresses, it can vary from between 5 to 50 years. These are dependent on what other factors are there, including genetics of that person and second or third risk factors being present. If you can disrupt the irritation, it can go back to normal liver. But if the irritation continues or there is a second cause comes in, then it rapidly progresses to cirrhosis of liver that leads to liver failure and cancer development, which then can lead to need for liver transplantation. But not everybody is suitable for liver transplantation. And cirrhosis itself is not one thing. There is compensated cirrhosis and decompensated cirrhosis, i.e., whether the functional aspects of the liver, even though it's scarred, is maintained or slowly getting damaged. And you can see death at 1 year can be about 1% with stage 1 compensated cirrhosis, progressing to 20% death rate at 1 year with decompensated cirrhosis stage 3, to about over 50% by stage 4. So with the progression of liver disease, we can measure them with certain scoring systems. Child-Pugh score has been there for over 40 years now. And as you can see, with Child-Pugh score, when the prognosis is good, at about 95% survival at 1 year, if you have got early stage disease, it can progress to about 50% mortality or over if you progress to child C. Similarly, 2-year survival shows similar stepwise progression. There is another score called Meld Score, and that is mainly used in liver transplant assessment as to who gets priority for listing. And again, there is a stepwise progression up to about 70% 3 months mortality if you have a significantly raised Meld score. So, as I said, not everybody with liver disease gets to transplant or is fit for transplant. And while palliative care has been well known in cancer for a long, long time, there is an important push for palliative care and end-of-life care in liver disease. This is still a significantly neglected part of liver disease care. But this is where we need to concentrate on, because we can make a significant difference to the quality of life, even though we may not be able to make a difference to the quantity of life in advanced liver disease. So the take-home message I will tell you is that while alcohol still is the commonest cause of chronic liver disease, there are many other causes. The etiology of liver disease has minimal effect on clinical manifestations of liver damage. People with chronic liver disease can be asymptomatic for long periods of time. During this asymptomatic phase, the disease can progress, causing liver fibrosis and cirrhosis. Vast majority of liver disease in the UK is preventable. Once liver's function capacity is decreased, progression can be fast at high morbidity and mortality. Thank you. Mishi, I think you're on mute.
Thank you so much, Dr. Das. Really good insight into liver disease, and as I think we all feel that it's alcohol, but obviously there are a lot of other reasons relating to liver disease rather than alcohol only. Alcohol obviously does not help. I've got a number of questions which people have posted, and if I can take each one of them, and if you can provide your opinion on that as well.
Thank you.
Okay. So the first one, and all these questions are in no particular order. So the first one is somebody saying, can fatty liver be reversed with weight loss?
Oh, yes, definitely. Till now, the only thing that has been shown to improve outcome with fatty liver is weight loss. So what we say is you don't need to lose 2 stones in 2 weeks, and that's actually more problematic. What we'll say is aim for 5% weight loss over a 6-month period, and that will prevent progression. If you can aim for about 7% weight loss over that same period and maintain it, that will improve inflammation in the liver. And if you can improve that to 10% weight loss from your baseline, and importantly, maintain it, that will help in reversing scarring to an extent.
Thank you for that, Dr. Das. The second question, does diabetes tablets, example metformin, affect the liver?
Yes, there are several diabetic medications that can affect the liver, mostly in good ways. So at the moment, there is a medication called pioglitazone, which came out about 15 to 18 years ago as a diabetes medication, but did not get very commonly used because it had some other side effects. But you may have heard about NICE, the National Institute of Clinical Excellence and Health Care. They have actually approved the use of pioglitazone in people with non-alcoholic fatty liver disease with advanced fibrosis as a treatment option to reduce the progression. Similarly, metformin increases the effectiveness of insulin in the body. So it allows insulin to work better. There are also other newer medication like semaglutide or dapagliflozin that are being used. They also increases how efficiently insulin can work. And if you reflect back, we talked about insulin resistance as a driver of fatty changes, not only in the liver, but along the blood vessels, in the heart and muscles. So if you can improve the insulin resistance, that will improve the fatty changes, and that will improve the functioning of the liver.
Thank you. The next question is blood thinning tablets. Do they affect liver disease?
Sorry, I didn't get that. Blood thinning.
Blood thinning tablets, for instance,
That's
aspirin.
yeah. So aspirin or clopidogrel or ticagrelor, this directly does not have a huge effect on the liver. But how it's important with blood thinning products and liver disease is that one of the consequences of progressive liver disease is that the blood becomes thinner by itself because the liver fails to produce certain chemicals that are important in clotting. Also, there is a particle in the blood called platelet. Now, platelet helps in clotting. With progressive liver disease, the platelet count starts going down, and certain blood factors that help in clotting starts going down. So there is an increased risk of spontaneous bleeding, bruising. So with added anti-platelet agents or anti-clotting agents, the risk of bleeding increases.
Thank you. The next question is, does blood pressure and blood pressure medication affect the liver?
Yeah, sure. So again, blood pressure has got lots of causes of blood pressure, but certainly in terms of the insulin resistance and metabolic syndrome, which is one of the common causes of blood pressure, it's the pathogenesis or why blood pressure increases and why fatty changes in the liver happen is quite related. That when fat is deposited in the liver, it causes fatty changes in the liver. Similarly, the fat gets deposited along the blood vessels, making it stiff. And that stiffness of the blood vessels aids in increasing the blood pressure. So blood pressure lowering medications are needed in these patients, but there are lots of different types of blood pressure medications. Couple of them, like things called ACE inhibitor or angiotensin receptor blocker type medication. So common names being ramipril or losartan. This group of medications has been shown to be more useful in patients with non-alcoholic fatty liver disease, which also modifies insulin resistance and liver fibrosis to an extent.
Okay. Thank you. Right, so I've got a question here. It says, when someone has had jaundice in their 20s and has been treated and cured, does liver regenerate completely without trace of jaundice?
Sure. So jaundice is only one manifestation of liver damage. And when you mentioned about if somebody gets liver damage and then is cured of that, the simple answer is that if it is really cured, then there should be no long-term consequences. But quite often happens that while in the process of curing from an acute insult to the liver, there can be some structural changes that remains. So for example, if you have a bad burn on your hand, it will be red and hot and painful for some days. Then the red hot sensation, the pain, they starts getting better. The skin starts healing, scab forms, and the scab falls off, sometimes giving a bit of scar. So similarly, when there is an acute damage to the liver, the same type of process of healing happens. So compare jaundice to the red hot swollen skin of an immediate burn. As the healing process happens, the jaundice improves over time. But if the damage has been quite significant, as the liver repairs or regenerates itself, there is some residual scarring that can stay.
Thank you, Das. The next question is somebody who's saying that they've got autoimmune hepatitis
Mhm.
and that's under control. Is there any kind of specific diet that will help to support the immune system? Uh, being a vegetarian, is there anything that you can suggest?
Sure. So, in terms of diet and liver, and irrespective of what the cause is, and appreciate this person asked about autoimmune condition. Anything and everything in moderation, as long as you can maintain a good variety of nutritional elements, that you don't have too much calories. No, you can have too much calories from having lots of red meat, but also you can have too much calories from having very sort of fatty food in terms of ghee and things like that. So it doesn't matter exactly whether it's a vegetarian or non-vegetarian, as long as the calorie control is there and there is a good proportion of distribution of proteins, minerals, fat to an extent, and carbohydrate, that's good. What you need to avoid is too much of sugar that is simple sugars, because they causes rapid rise in blood sugar, and that can cause problem. And only if there is advanced liver disease with fluid retention, then controlling salt intake is quite important. But in early changes in the liver, it's not very important to control salt. It's only when there is fluid retention in late stages.
Thank you, Dr. Das. Okay, the next question is enlarged liver bad for health? If yes, how bad? And what can or should one do about it?
So, enlarged liver is generally a manifestation of either irritation of the liver or fatty changes in the liver. And that can happen due to a number of causes, including alcohol related swelling and fatty changes, non alcohol related fatty changes. And I briefly mentioned that just having a bit of fatty changes in the liver is very common. Now, if I go into the community and do scans of 1,000 people at random, almost 250 of them will have fatty changes in the liver. Their liver may be slightly enlarged. As long as there is no scarring in the liver associated with it, or severe inflammation in the liver associated with it, then it does not hugely matter. But while the fatty changes today may not be important, it may become important over time. So yes, if there is finding of increased size of the liver on a scan done for a certain other condition, it's worth asking the question, why is this enlarged? And if we can find the cause, we need to treat the cause to reduce longer term damage.
Thank you for that. The next question is, what blood test should one ask for to identify liver disease?
Okay. So there are three sections to this answer. So one is a set of blood tests that's commonly called liver function test as a group. That's what most of the time will be done. So these includes things like testing for bilirubin, ALT or SGOT, or AST or SGPT, and alkaline phosphatase. Now, these are only certain aspects of a liver's function or inflammation. That can give us a good idea of how functionally damaged the liver is. Then comes more specific blood tests looking at causes of liver inflammation. So if somebody is found to have abnormalities in the standard liver function test, then the doctors will ask for why is this happening? And as part of that, several other blood tests are done, like testing for hepatitis B or hepatitis C, testing for autoimmune markers in the blood, testing for excess iron, testing for genetic conditions that can lead to liver damage, like cystic fibrosis, Wilson's disease. So you're looking at blood tests for the etiology as to why the liver is getting irritated. And then we mentioned about the assessment of scarring in the liver. And there are now a panel of blood tests that are available that can look at markers in the blood that says, is there scarring happening in the liver? Now, this test need to be interpreted with caution because they may represent inflammation or scarring elsewhere and may not be specific to the liver. So say, I'll give you an example. So there is a condition called rheumatoid arthritis, which is a disease of the joints. It's an autoimmune condition. And one of the treatments of rheumatoid arthritis is a medication called methotrexate. Now, methotrexate is an immune modulator. But one of the side effects of methotrexate is it causes liver damage in a small proportion of people who gets methotrexate. Now, rheumatoid arthritis is associated with scarring in the joints or around the joint. So if this patient has abnormal liver tests on the blood counts, then the question to ask in the next set of blood results is to look for whether there is autoimmune hepatitis causing damage, because several autoimmune conditions be present in the same person. So if already there is another autoimmune condition, the patient can have another autoimmune condition more easily than the general population. So somebody with rheumatoid arthritis can have autoimmune liver disease also. So it's important to work out what is causing the liver inflammation. Is it autoimmune hepatitis coexisting with rheumatoid arthritis? Or is this due to the methotrexate that is causing the liver inflammation? So it depends upon what you're trying to assess. The set of blood tests will be done in that way.
Thank you for that, Dr. Das. Okay, I've got one more question. Okay, here it's right. So someone's had TB in the past,
Mhm.
and the doctor at that point in time said that he had fatty liver. Would that be the cause? Would that be due to TB?
TB?
Yes.
Okay. So in terms of TB, again, in the context of UK, if we look at it, the main group of people that are diagnosed with TB in the UK, a vast majority are coming from Southeast Asia, Indian subcontinent, and Africa. Now, with TB, the same areas of population has an inherent insulin resistance, and a prevalence of insulin resistance is quite high in the same group of people. And therefore, diabetes is much more common in Southeast Asian population. And associated with this insulin resistance, diabetes and hypertension, fatty liver is also very common in this group. So there is the same risk factors are present in this group of population. So the fatty liver may just be a coincidental factor with TB. But what's important with TB is not the disease itself, but the medications that are used in treatment of TB. So two common medications used in treatment of TB are called isoniazid and rifampicin. Now, these have been used for many, many years, and we know them very well. The problem with them is that these are common causes of drug-induced liver damage. So somebody, when they're starting on treatment of TB, they will generally have their liver function test checked to make sure there's no major changes. If there are changes, then the doses of the medication may need to be monitored more or adjusted. And also, once they get onto treatment, the liver function tests are monitored to see if they are getting any damage to the liver from those medications.
Thank you for that. Next question I have is there any link between chronic chronic kidney disease
Mhm.
and liver disease, or between COPD and liver disease?
Okay. I'll talk about the COPD and the liver disease first. Generally, there is not a very direct link, but conditions like cystic fibrosis can cause chronic lung disease, not typical COPD, but chronic lung disease. And that can be associated with fatty liver disease. Similarly, with alpha-1 antitrypsin deficiency. Now, this is a chemical alpha-1 antitrypsin that helps in protecting the lung from damage from dusts and smoke. So in people who get alpha-1 antitrypsin deficiency disease due to the genetic condition, they are much more prone to developing premature damage to the lung. So emphysema, which is a form of COPD, develops at a much early age, rather than when it's done with COPD associated with chronic smoking or dust and fumes and workplace damage. That tends to present in a much later age. With alpha-1 antitrypsin deficiency, there is also a chance of getting liver damage. So yes, there is some conditions where both can coexist. In terms of chronic kidney disease, again, chronic kidney disease is not one condition, and there are lots and lots of reasons why chronic kidney disease happens. Common among them would be diabetes, high blood pressure, and now see how the same conditions causes chronic liver disease on one side and also predisposes to chronic liver disease on the other side. So a same person with chronic kidney disease may well have chronic liver disease at the same time, because the etiology of both the conditions can be the same.
Thank you for that. One more question.
Mm-hmm.
Long-term use of antibiotics
Mm-hmm.
and its effect on liver.
Okay.
Your view, please.
Sure. So in terms of long-term antibiotics specifically, generally before they get to long-term, if they are causing damage, it will manifest within the first few weeks of having, or first few months at the most of having antibiotics. The main long-term antibiotic that can present with is at a later stage, several months or even a couple of years into using it, is a medication called nitrofurantoin. Now, nitrofurantoin is an antibiotic that is prescribed in people with recurrent urinary infections to try and reduce the frequency of urinary infection. Now, nitrofurantoin can cause no problems with the liver for several months and then cause liver damage after that. But generally, long-term antibiotics otherwise are not a major cause of chronic liver disease. But as I say, methotrexate is a typical example of long-term medication that causes chronic damage.
Thank you very much for that, Dr. Das. I think there aren't any other questions at the moment. Right. Okay. I think we have come, and it's coming up to 1 o'clock as well. So we're going to end the session there. Dr. Das, thank you very much for this insight into liver disease. As I think, as you said right from the onset, a lot of people, as soon as you talk about liver disease, people just associate that with alcohol, and a lot of us, and I particularly have realized that there's a lot more to
Mm.
liver disease than alcohol. Thank you so much for this wonderful insight. Appreciate your time as well. Thank you.
Thank you very much.
Bye bye.
Bye-bye.
Can we get a recording of this session?
Yes, you can. So the recording, I've sent my telephone number. If you can send me your number, and I'll send a link to
Thank
the
you, because
recording.
I went to Jamaat Khan. I missed the first portion.
Okay, no problems. My telephone number is 0794 182.
Can you put it in the chat, please?
Yes, it's okay. Yeah, I'll do that. Just a second.
Thank you.
Are you in Canada?
I think,
Yes.
Umeshji,
Yes.
somebody has just posted
Oh,
about.
I got the recording from YouTube.
Okay. Yeah, you can get it straight from there as well. But if you send me your number, I will make sure that you get the recording as well, and
Sure.
you'll get a recording. You'll get about information about future events as well.
Sure. Thank you so much.
Okay, no problems. There is one more question, I think. Is that right, Doctor?
So is it Gayatri most likely?
Yes.
Recently, I was referred by my optician to GP to investigate liver function, as had yellowish eyes. I'm on metformin and losartan. Is that right?
Yeah.
So this could be simply that you may have a condition called Gilbert's syndrome that I mentioned about earlier. It's one of the commonest genetic causes of having slight jaundice, and is of no consequence. But also, if this is true liver disease associated, so I can see with your medications that you're diabetic, you've got high blood pressure, you've also got thyroxine, which may suggest that you have an autoimmune thyroid condition. Those are independent risk factors for having associated liver condition. So what will be important is to have the test done to look at whether it's just simple jaundice secondary to Gilbert's disease or Gilbert syndrome, or is there more to it? So I would encourage you to get your consultation with the GP, get the blood test done to assess whether there is evidence of liver damage as such, and then looking at causes and degree of liver damage will be important. So I would say, rather than being worried about it, I would suggest take the step to go to your GP and get it tested out so that you know what's going on.
That's great. Thank you. Thank you so much, Doctor. And thank you, Gayatri ji, for posting that question. I think that's it. I've just got to take one more telephone number, and we are going to end the session now. That's it. Great stuff. Thank you. Thank you, everyone. And hope to see you soon. Thank you. Bye-bye.
Bye-bye.